Scleral buccal intrusion, a surgical double-bind situation. We assure there is no financial interest in the making of this video. Extrusion, erosion and intrusion of buckling are rare but important complications of scleral buckling. Intrusion occurs when the implant has eroded and protruded into the vitreous cavity. It may either be the material implanted on the sclera or the suture materials. Here we present a case of a 55-year-old female patient who visited our vitreoretinal services department with complaints of sudden decrease in right eye vision for one day. She had history of scleral buccal surgery in right eye 6 years ago with visual acuity of hand movements at presentation. She had history of left eye failed VR surgery 10 years ago with no perception of light at the time of presentation. On ophthalmic evaluation, her right eye had visual acuity of hand movements, anterior segment was within normal limits, pseudophakic, fundus examination had no view due to vitreous hemorrhage. B-scan showed vitreous hemorrhage with near total retinal detachment with buccal effect. Patient was planned surgery under local anesthesia. A standard 25 gauge pars plana vitrectomy with endo laser, fluid air exchange and 5000 centistoke silicone oil was injected. Post-operatively, patient had vision improvement to 5/60 but persisting subretinal fluid at inferotemporal quadrant. Post-operative 1 month, patient was advised to undergo barrage to contain the SRF, following which patient had further deterioration of vision to hand movements. Patient was then advised resurgery. Under subtenon's anesthesia, 3 25 gauge ports were placed. After silicone oil removal, inferotemporal quadrant subretinal silicone oil was noted with barrage scars around. PVR membranes were tried to peel and it was noted to be skytic vitreous membranes. Due to tractional force while peeling the membrane, the barrage scars and previous drainage retinotomy opened up. At inferotemporal quadrant, it was found to be subretinal migration of silicone oil. Peripheral retinectomy was done to remove the oil. Normally, oil should float up, but that was not the case here. The oil was removed mechanically. After removal of oil, buccal intrusion was noted. As silicone oil and silicone buccal results in physical interaction and strong bond is formed, oil does not come out freely and even with suction and needs mechanical removal. After removal of oil, perfluorocarbon liquid was injected to flatten the retina. Interaction of perfluorocarbon liquid with silicone oil resulted in dissolution of small amount of oil into solution over time, and also due to ongoing inflammation and fibrin release intraoperatively led to a formation of hyperviscous solution with increased shear viscosity and characteristic sticky bubble formation. This hyperviscous solution is difficult to remove even with aspiration of 600 mm mercury vacuum. Checkerboard pattern endolaser was applied to achieve complete retinochoroidal adhesion. .360-degree retina was inspected for other breaks. Perfluorocarbon liquid was replaced with 5000 centistokes silicone oil. Buccal was left in situ as there was no signs of infection. It was the only seeing eye, and removal of buccal would cause large scleral defect and chances of bleeding, hypotony, phthisis. Early post-operative period was uneventful with attached retina under oil. With stable vision and intruded buccal, patient had best corrected visual acuity of 5/60. It can take years for erosion or intrusion to occur after the placement of silicone scleral buccal and is reported approximately 4 out of 4,400 cases. The precipitating factors include thin sclera, presence of glaucoma, severe tightening of band, high myopia. It can either present as hypotony, vitreous hemorrhage, retinal detachment, endophthalmitis. Depending on the indication, it can be managed by cutting the encircling band, removing of exposed segments of scleral buccal elements with other elements left in place, remove of all elements along with sutures, or observe. There are various studies and case reports regarding the management of buccal intrusion. Management of each case is different and should be tailored accordingly. The intruding buccal may be left intact unless there is significant threat to integrity of ocular structures, recurrent retinal detachment, or vitreous hemorrhage. If buccal removal is planned, then scleral graft should be kept ready as there is high chance of large scleral defect. Surgery, if indicated, should be performed diligently and with careful handling of the tissues. These are my references. Thank you.